Welcome, everyone. Today, I'm thrilled to be here to talk to my good friend, my colleague, and an airway expert, Dr. Layne Martin. Dr. Martin, thank you so much for sharing your time with us and your expertise with us today.
So thanks for having me, Doc. Always a pleasure to see you. Talk to your listeners is great. And yeah, I went down this airway journey. I don't want to say by accident, but kind of backed into it through Victor Avis, who you know really well. And my career has kind of taken this odd path. And I was in a restorative dental practice after getting out of the Navy. And I taught with a group of people, and Victor was one of them. And we would discuss all these big full mouth rehab cases and cases with collapsed dentition. And Victor would always say, I bet you they have an airway problem. Next case, I bet you they have an airway problem. And I'm like, man, this guy is getting on my nerves. And finally, after the 50th time, I'm like, all right, explain to me this airway thing. And next thing I know, I'm doing an airway residency with Barry Raphael. And, it's always my story. I realized that I missed these things for so long. And I couldn't unsee them. And I ended up going down a rabbit hole. I sold my practice. I went into ortho, then got boarded in sleep through the AADSM. And then I met my partner, Michael Gelb, who's a world-renowned TMJ and airway specialist. Really out of the gate, it was just us teaching dentists about TMD, airway, ortho, and in my background, also restorative. For now, it's the hottest topic in dentistry. And I always say it's really hard to kind of like think about it of where I came from and where I am now. And it's really about meeting the dentists where they are. And it's looking at dental patients very differently. And the simplest way to look at it is if you see a patient that has wear on their teeth, most likely they have an airway problem.
Wow. That shows how epidemic it is, because how many people have wear on their teeth? Many.
Yeah. And that's really the thing is like, we have to look at it, especially in the dental community, look at it that people that are clenching and grinding, they're going into sympathetic overdrive. They're going into fight or flight. And the analogy I always use is if you're speeding on the highway and you see a cop on the side of the road, what happens to your body when you see the police officer? Your heart rate goes up, your blood pressure goes up, and you clench down. You go into fight or flight. Unfortunately, if someone has cardiovascular comorbidities or other problems, especially at night, if they have snoring, sleep apnea, upper airway resistance syndrome, that could be happening 200 times a night. That's why these patients are presenting on multiple meds for blood pressure or on acid reflux meds or with AFib.
Wow. Such a good point. And it's, what you talk about just in these few minutes makes me think of how airway used to be kind of on the bottom of my list and afterthought, even when I was rounding in the hospital. Like if it was an overweight elderly, particularly male, not always male, but we would measure the neck and think about sleep apnea. Now we know like it's a continuum, like it's a, multiple contributors to poor sleep and poor oxygenation at night, right? It's not just sleep apnea. That's kind of the classic, yes, we've documented you stop breathing and you stop breathing so many times, but people are in a world of hurt early on if they're just upper airway syndrome, as you talked about, or just clenching and grinding is indicating there's decreased oxygenation at night. So speak to that a little bit, because now it's like I start with that. Like we have to first rule this out or nothing else is going to get better. It's kind of moved up to the top, I would say.
Yeah. And I mean, I think for us as dentists and even physicians in treatment planning, it's airway first.
Yeah.
In terms of the dental population, when I see a patient with worn down teeth, the simplest thing when I talk to hygienists, like a normal front tooth, a normal central incisor should be between 9 and 11 millimeters.
Okay.
And I made a good living building up 4 and 5 millimeter centrals. And what would I do? I'd make people's teeth longer. I'd try to make them look younger. But really in what I was doing is I was trapping their lower jaw back. And it's all about your tongue. Your tongue's attached to your lower jaw. And I made so many of those people worse without realizing I was making them worse.
Wow.
So when I talk to a dentist or a hygienist, I'm like, if you see someone that has wear on their front teeth and they don't have a parafunctional habit where they chew pens or their fingernails, they have an airway problem. And then the next question I ask is, if you have a trauma patient on the ground and you need to do CPR on them, what do? You jaw thrust them. Well, these people are jaw thrusting themselves all night to keep themselves alive.
Such a great analogy. Such a great analogy. And tell me this, if this is correct or not, but I know you have a lot of experience in orthodontics more recently, as you mentioned, and everyone's rethinking orthodontics, right? Because the reason people need orthodontics a lot of times is they don't have room for their teeth, and it's because of the bone structure. And so rather than just making it beautiful, you're now making it beautiful and opening up the airway or ensuring you're not closing the airway, right?
Yeah, so I tell you, and Michael Gelb and I say this all the time, orthodontics, nothing to do with teeth. It's brain development in kids and kind of brain fog in adults, but it's airway issues, right? So all these kids with ADD, ADHD, I would even say some kids on the spectrum, they're not getting oxygen to their brain. And they're not getting oxygen because of large tonsils and adenoids, like nasal resistance. So it all starts with nasal breathing. The last piece is anatomy, but it's really about it. And especially in kids, and if you think about it from an embryologic standpoint, our lower jaw grows after our upper jaw. So when you see little kids, their faces are really convex, their lower jaws are trapped back. So I think we need to look at orthodontics differently in terms of early intervention, no longer waiting until the kid's permanent teeth are in, like getting to these kids at 4, 5, and 6, and just looking at it differently. The simplest way to say it is wider and forward.
Okay. And I know you're involved in a lot of research. Tell us a little bit about your research, and then tell us about, I know you're an entrepreneur, on your own and in the academic setting and with Dr. Gelb are developing various treatment regimens. I don't even want to just say devices, but various ways to help with this problem. Just give us a little snippet of what's going on in this forefront.
Yeah, so when Michael and I got together, it was really more about educating dentists and physicians. When I was in my ortho program, I worked for an ear, nose, and throat doctor. And I would go in every Saturday and I'd insert oral appliances or mandibular advancement devices. And what I realized was, I'm like, wow, these are Band-Aids. Because I had 25 and 30-year-olds and and they're asking me, Layne, do I need to wear this for the rest of my life? And I'm like, not if I can help it. And I don't think that's acceptable medicine or dentistry, giving someone an appliance for 60 years. And so when Michael and I got together, I looked at Michael and I was like, I think I can make a better appliance than what's out there. But not only that, I can make something better. I could take your intellectual property and your father's, so the lower Gelb, which is a repositioner, which is bringing someone's jaw forward. And I'm like, we can make a better sleep appliance or mandibular advancement device. And that's a great way to jumpstart orthodontics, because it's the same thing, the same premise of what we use in orthodontics as functional appliances. It's a way to get someone's jaw forward. So that's kind of what we've done. We developed the Airvada mouthpiece, and we just got FDA clearance 2 weeks ago for mild to moderate sleep apnea. We're filing for PDAC Medicare approval now, and then we're also submitting a 510K to treat severe sleep apnea.
Wonderful. That's great. Do you see, this might be a little bit of a rabbit hole, but one of the things that I'm talking to a lot of people about is you just mentioned mild and moderate sleep apnea and then severe sleep apnea. And are you involved in any discussions? I know we have them like kind of curbside consults, so to speak, but like what's happening in the world of research in terms of redefining airway issues? Because there are people that have mild sleep apnea that their oxygen levels, based on any way you measure it, a watch pad, a sleep image ring, fill in the blank, their oxygen levels drop sometimes to 79, and maybe their average all night long is 92. And I just remember when I was in the critical care unit, we would run down the hall if somebody's pulse oximetries dropped below 96 and make sure they were, what's going on? Wake them up, let's breathe. What are your thoughts about that? Or what is going on in the discussion in the world of research?
I think the diagnosis of sleep apnea is going to be very different in a year or two, because I think they're going to go away from apnea hypopnea index and look at more like what you're saying, hypoxic burden, I think is a bigger issue in oxygen desat. And I can't comment to it. I don't really know.
Yeah.
I know that when we filed our submission, we put all those parameters, you know, a lot of it was AHI, but a lot of it was looking at the person's oxygen desat. It was also looking at snoring. You know, I don't love the metrics, to be honest. I took a sleep test and my number was 1.8, but I was snoring. I was definitely tired a lot. I would need coffee by 4 or 5 o'clock every day. And I felt like I was definitely starting to get a little bit of the brain fog. So according to the insurance companies, I was fine, but I definitely was not fine. So I don't love the metrics. I love looking at it like, all right, you know, a little bit subjective, right? Like really finding out what the patient's feeling, their symptoms, their clinical signs as well. And then is looking at really their oxygen levels. Because, I mean, you know more than anyone too, when you measure age, their apneic, you know, that apneic episode or their, you know, that hypopneic episode, I don't know how long it's truly lasting.
Right. Yes.
You know, I know it's an incident. I know it's 10 seconds, but is it 30 seconds? Is it 4? Like, I don't really know.
Yeah, such a good point. And there's so many things to talk about around that. But one is, you mentioned it, like if someone is able to do, like I've had people come in before that do highly intellectual work for their job, like maybe a lot of mathematical equations or something along that line. And they're like, I just can't do it as quickly as I used to. I'm struggling to get my projects done, things like that. And if you improve this problem we're just talking about, I guess it's a subjective measure, right? But they're like, I'm still good at 2 PM doing my calculations. I'm back in the game. If you can get them sleeping better, and they're not going to sleep better till they're breathing better at night. You see that difference in their performance level, as you mentioned, their ability to think and focus and those kind of things. So unfortunately, that falls into a subjective category, but in our world, it's a very real metric, as well as then maybe you can get them off a blood pressure medicine or two as well.
Well, I mean, if I look at someone's medical history and I see they're on multiple meds for blood pressure and they're on acid reflux meds, I know they have some type of apnea. I don't know the severity, but
yeah,
you know, that's the point, right? Like if someone's heart rate and blood pressure are spiking all night, there's no way one med is going to be able to control that.
Right. Exactly. Such a good point. The other thing that I wanted to say about that is, you talked about that the device can be maybe a bridge or have its place, but it's a Band-Aid of sorts, or a lot of times can be used as inappropriately as a Band-Aid, calling it good, which is not the type of practice you're in and not the type of research you're doing. But it made me think of CPAP, because CPAP was never intended to be a long-term solution. It was meant to be kind of a life-saving intermittent use till we figure out the problem type of device. And now that's the only thing a lot of people do. And it's a terrible long-term use fix for this problem, in my opinion. What are your thoughts around that?
So it's such an important point. The other thing, you know, here's the deal. I mean, I'm part of the ADSM, and I think it's a great organization. And I think that dentists have to understand something super important. An oral appliance and mandibular advancement device, it's a medical device. And it's a medical procedure. And I think that working with people like you and Michael Gelb, and working with our physicians, and you know, Jonathan Lowndes, the pulmonologist that we use, and we work with a lot of ENTs. It's really a collaboration of working alongside people like yourself to figure out, like, all right, how do we get this person feeling better, sleeping better, mitigating their symptoms, but really trying to get them off of CPAP, not have them have to rely on a mandibular advancement device for the rest of their life. The beauty of what we could do as dentists, the first line for me is always orthodontics. The second would be restorative dentistry, of just getting their jaw in a better position. The last thing is, yeah, they could use our appliance forever, but I don't even think that's a great solution. So, I always look at it two ways. I have a branch where if I have a child that has an airway problem, pediatric ENT is the first consult, then right into ortho. If I have an adult, I want to get them feeling better and sleeping better. I put them in an oral appliance because I need to make sure that they don't have a nasal patency issue. Then I need to make sure they don't have a soft tissue problem. And the last piece is orthodontics. But when you have someone that, their lower teeth are like this, there's no room for their tongue, doing something like Invisalign or clear aligner therapy and uprighting their molars will give them a huge amount of relief. It'll give them more tongue space. It'll open up their vertical, things like that. You could bring their jaw forward, because the people that might not understand oral appliance therapy, it's always like, well, the person's bite's going to change. I'm like, I don't care if their bite changes. Why would I want to leave someone here trapped back if I could get their jaw here and bring their tongue forward? And then it's really more of, all right, once they're here, do you do orthodontics and move their front teeth out of the way? Do you build up their back teeth? So I think that it's really about collaborating with the physicians. The physician has to make the diagnosis. We have to work in conjunction with the physician. And there's certain people that are going to need to be on CPAP. Absolutely. And the patients that are on it and that are compliant with it, I'm all for it. I just would want to find a way of, like, could we take the pressure of the CPAP down? Could we maybe find a way to not have to have them rely on CPAP forever?
Wonderful. I think that's such an important perspective. And to summarize that, or to sort of make it wrap all together, I would say it takes a thoughtful approach. As you said, it's a medical procedure, or it's a medical problem. And it takes collaboration, and then it takes a thoughtful approach, because it's not just I don't know, like putting on a tattoo, it looks beautiful, call it good. No, that's not what we're talking about here. We're talking about a person's life and the extent of their life and the quality of their life. Yeah.
Yeah. And there's been a significant recall on CPAP through Philips. We do work with Inspire. I think it's a newer procedure. It's the hypoglossal nerve stimulation. I think that's, in my mind, I think a better alternative to CPAP, but it's limited. It's limited to BMI. It's a surgical procedure. And that's the other thing. Do you put a 30-year-old in Inspire and then them like that forever? I don't think that's a great solution either.
Right. Yeah. I agree with you. And even like, I have several, actually two right now, but over the course of years, the last few years, have had several that we've considered Inspire with, and some who've gotten it. But even in a 50-year-old or 60-year-old, now that we're talking about longevity, where we talk about, we want you to be enjoying your favorite activity at 95, if that's how long you want to live. Or if you say, I'm a biohacker and I plan on making it to 120, well, you want to be on your bicycle at 120 or whatever it is you want to do. So even putting Inspire and not solving this problem for decades to come, I'm not saying Inspire doesn't, but I'm just saying this thoughtful approach, which the way you talk about putting Inspire in a 30-year-old just made me think of how we're all extending our lives. We have the capability to do that now, but we don't want it to just be a surviving kind of life. We want it to be fully engaged. So thinking about this.
Yeah, and, I'm faculty at my ortho program, and when I go in there, and it's not limited to just orthodontists, but I want them to understand the impact they could have. I always say, I'm like, you guys have such an incredible opportunity to impact people's lives by just doing better orthodontics. Sure. And I think that that's so important, because think about it. It's every dentist now does Invisalign or some type of clear aligner therapy. And it's like, if you do it better than most other people, you're going to help out these people so much. You're going to mitigate so many of their symptoms. That's the impact and a gift that dentists have of really helping a medical situation. And I just got in an argument with a physician that I'm friends with who does a lot of appliance therapy. And he's like, oh, I know, there's no proof that ortho does that. And I'm like, first of all, there is proof. Second of all, it's still better than leaving someone's jaw trap back and leaving them with no room for their tongue. You're going to impact them and you're going to mitigate symptoms. Am I going to cure their sleep apnea? I don't know. But am I going to make them better? 100%. If you do better orthodontics and you move the person wider and you get their jaws forward and get room for their tongue, they are going to be better off for sure.
Wow. Yes, for sure. I mean, even if there wasn't research out there, and there is, but even if there wasn't, you don't have to be in the clinical arena very long to see enough cases to know that that's true. So I wanted everyone to understand how you're a serious academician, if that's the word, academic advisor and lecturer and researcher, not to mention clinician, but and with a very serious mindset about it all, but a deeper dive than most people take. Because I felt like, for one, that information isn't out there widely enough. We know that to begin with. And secondly, because we want to talk about a pillow. And I didn't want to start with that because people may go, oh, okay, great, they're selling a pillow. No, that's not what we're talking about here. We're not talking about we're going to give you a comfy pillow and we're just trying to sell thousands of them. No. But there are therapies that are novel approaches. You've developed one that I think is fantastic to solving one of these problems anyway, or making this problem better, because it does take a lot of iterations to get to the right, I wouldn't even just say diagnosis, but not diagnoses, like several contributors to this problem of decreased oxygen at night, poor sleep at night, etc. So tell us a little bit about the pillow. I want the story too. I love the story of how it's developed and where it's being manufactured and all of that. And when is it available? Because, I want a bunch of them, because I want a bunch of them for my friends and family as well as my patients. So let's talk about the pillow.